what percentage of your patients or you have had peritoneal only carcinomatosis, since you have spoken about HIPEC not adding much survival? In practice, are there any patients of yours or Dr. Senthil or the other medical oncologists practicing who had limited peritoneal only metastasis and they have gone for a HIPEC and have been doing well?
My own practice, no. I have heard anecdotal reports from people who are practicing elsewhere, but in our own in my practice, we have probably, I can think of a couple of patients who had 1 or 2 nodules seen during surgery and were removed, which later turned positive. I think maybe hardly 1 or 2. I think Senthil sir can add on. That's maybe the numbers.
You know, they're very copybook surgeons that way, though they're very aggressive in what they do as long as it's by the book. So when they see peritoneal disease, they will just biopsy and come out. It's a rare patient that we have done. Pratap Reddy sir is here, so he can probably talk on my behalf or he can answer that question. I really can't remember a patient who had even limited peritoneal disease with stomach cancer whom they went ahead and resected.
Why I put that question is probably these are not the patients who have had florid peritoneal metastasis picked up on initial CT imaging where we have labeled them off of saying is metastatic disease. But these are the ones on staging lab initially, and then where the surgeon has seen he wanted to take the cytology at that point of time. That is when probably you pick up these patients who have PCI very less. You're saying 6, probably we take it practically most of the times as PCI less than 10. Maybe these are the patients, they do come back from a medical oncologist sometimes where they complete at least a therapy of 3 months and we go ahead and operate. A very small number I would say, but still there is, I would say, the role for HIPEC in such patients.
So the role of HIPEC is extremely, I think, dependent on our hopes and our wishes rather than actually having any data. So we can depend on either of them as we want, so that's fine.
In carcinoma stomach, our policies, even if there is a single met, we biopsy, send for frozen. If it's positive, we back off and come out.
That's what generally most people do.
Having said that, I'm a believer that if you really want to do any kind of cytoreductive surgery for CS stomach, it should be in a trial, pre-approved trial by the ethical committee, not otherwise.
So my second question following that up, so why do you think, either HIPEC has not come a long way compared to other primaries, like compared to ovary or other primary sites?
So I think the first question, has HIPEC come anywhere? I think that's the first question which me and Dr. Senthil will ask. I don't think we believe in it anywhere. The data is not strong enough. I think the simple reason is the HIPEC is theoretized to work very well by spreading across and so on and so forth. But just like our immunotherapy doesn't cure, same thing HIPEC doesn't cure. So I think that's the answer.
I think that's a very radical statement. In low grade, in low grade tumors, mucinous tumors.
Yes, sir. I'll qualify my statement. Pseudomyxoma peritonei,
biologically,
peritoneal mesothelioma.
Non-aggressive, cytoreductive surgery, HIPEC does work. It has been proven beyond doubt.
I think
where it is not proven, I think you should accept it that it doesn't.
I think clearly where systemic therapy is not effective, I would put it that way. That's where we always discuss in our tumor board saying, okay, this mucinous carcinoma is unlikely to respond. This is a young patient, fit patient, limited peritoneal disease, okay. Because I just cannot do anything at all, they are more than happy to take that up and do. So that's one point. I totally agree with both of them. The second is, you spoke about ovarian cancer. Recently, the ESMO guideline has removed HIPEC from its recommendation. Okay. The earlier recommendation actually had HIPEC as one of the options. Now, the problem is we don't separate aggressive cytoreduction from cytoreduction plus HIPEC. I think 95% of the job is actually done by the aggressive cytoreduction. It's probably that 5% incremental benefit that you are getting because of HIPEC. It's because we so strongly believe in it that we are refusing to give that up. I have a feeling that with lesser morbidity, you can just do aggressive cytoreduction and your patients will do as well as you might get with adding that morbidity, doing that HIPEC, and getting that meager additional benefits in a situation where systemic therapy is effective. In a situation where systemic therapy is not effective, limited disease, good performance status, good organ function, without any doubt, I think that's the way to go, because I don't have anything to really offer. So that's the way I look at it. So there is a role. I think we've not been able to clearly define that role, either in terms of patient selection or in terms of biology. It totally seems to be revolving around technicality and skill rather than disease biology and patient selection. I think that's where we have gone wrong. I'm sure it'll find a place, but it'll find its niche area, but we need to wait.
Very, very valid points, Dr. Senthil. So that's the intent of those questions. I do not want to take the discussion towards PSM, but that's where I think the tumor biology plays a role. And there are niche area of patients where, beyond stage 4 who have limited peritoneal disease, and it is the technicality of cytoreduction which we as surgeons find it very difficult. Than the HIPEC itself, that would add much survival to these patients. So one last question to you, and the other medical oncologists also can take it as well. In patients, you put FOLFOX or CAPOX as the backbone in metastatic patients. In patients with DPD-deficient patients or who have progressed on FOLFOX or CAPOX, what is your take and how would you manage?
I think DPD has nothing to do with other chemotherapeutic agent. It has something to do with 5-FU related toxicity. So if you have a complete absence, then we don't use it at all. If there is a partial absence, then you start with a 50% dose and escalate it every cycle to reach a toxicity that is okay for that patient or bearable for that patient. Alternatives would be to use another drug called S1, which is, the last couple of years is available in India. There are some people who believe that even S1 is to be carefully used when you have a complete absence of DPD, but that's an alternative that you can do. But when it comes to oxaliplatin, irinotecan, and all the other drugs, it's okay to
Even
use it in
paclitaxel
patients
can be
with-
used.
that's right.
Paclitaxel
So
and
it is
carboplatin can
okay
be used
to-
in this
it's only to do with 5-FU and analogs.